Okay, so the next set of medications in psychiatry, we have our antidepressants. Right. So earlier we covered for lithium for bipolar and all the antipsychotics for schizophrenia, as well as other case scenarios of psychosis. And we looked at buspirone with the anxious waiting for your bus for general anxiety disorders. Now, for antidepressants, there's mainly two receptors that things are going to focus on. So now if you're ever looking at a question about antidepressants or something, you're probably not working with a medication that has something to do with dopamine receptors, which are more so relevant for psychosis. So on the noradrenergic side, we have, of course, the formulation of norepinephrine, and on the serotonergic type, we have the formulation of serotonin. So you can see the first thing right here, MAO inhibitors basically stop monoamine oxidase on both sides. Monoamine oxidase, what it does is after serotonin has been taken back up, it breaks it down into metabolites, right? So now you stop the breaking down of serotonin basically. And the other group you're seeing here are ways of basically stopping reuptake, right? So you have your SNRIs, serotonin norepinephrine reuptake inhibitors. They stop you from taking medication, or well, taking the hormone back up from this middle area in between. Right, so the norepinephrine or the serotonin or both will continue to just float around, right? SSRIs focus only over here. SNRIs focus on both things. The last few things you have trazodone, which also stops reuptake. And here you have bupropion, which stops reuptake of this. Right? So bupropion is often, especially when you're new to this, often mistaken with buspirone. You get confused when you see both answer choices together, especially if this is one of your later questions in like the last block of your step 1. And that's a very easy to avoid confusion with the mnemonic we discussed yesterday, right? Anxious waiting for my bus. I get anxious thinking the bus is gonna leave. Right? Generally, it's anxiety disorder taken care of by buspirone. Bupropion is actually a norepinephrine reuptake inhibitor. TCAs, which have terrible side effects, are also in this class right here, but you can see TCAs work here as well. Alright, so TCAs and SNRIs pretty much work very similarly. SSRIs are just selective serotonin reuptake inhibitors. Trazodone is just like an SSRI, it stops serotonin reuptake. And bupropion is kind of like a TCA, it stops norepinephrine reuptake. The last thing here in the middle, you have mirtazapine. Right, so this is an alpha-2 blocker. It's not really a psych medication per se, it's an actual alpha-2 blocker. And alpha-2, remember, was the receptor that was your anti-sympathetic, right? Although alpha and beta receptors are supposed to be for sympathetic output, alpha-2, when you turn on the alpha-2 receptor, you turn off the rest of the sympathetic outflow, right? So if you block this, you avoid turning off sympathetic outflow. Now the point here, sympathetic versus parasympathetic, the point is that when somebody is going through depression, most of their output is parasympathetic, right? Most of the depressed person's output is just resting and digesting, not being active, running, stuff like that. None of that fight or flight stuff. So you want to help initiate more fight or flight level kinds of things, which will then of course also lead to release of endorphins, which are natural antidepressants, if anything, amongst many other things that they can do for us. So that's the general schematic of things you're seeing here. Real quick simple question right here from USMLE RX. It says 22-year-old man with schizophrenia is being treated as an inpatient with the first generation antipsychotic medication. Several hours after his initial dose, he develops involuntary muscle spasms, particularly in his facial muscle. To which class of drugs does the indicated treatment for this patient's adverse effect belong? So if he was just started, right, several hours ago, he just got his initial dose, then the only thing this can possibly be is acute dystonia, right? It can't be tardive dyskinesia, which is one of the last things that occur, and it's not one of the middle things either, like the akathisia or whatever. This is happening within the 24-hour period, so this is acute dystonia. Now, treatment for all of those was generally benztropine, but there were other things you could use in between as well, right? So we saw that in our last session. Acute dystonia, right? We had benztropine here. Same thing for akathisia, benztropine, Parkinsonism, benztropine. But then there were other medications that I told you guys are usually going to be what you're actually tested on in your step one. That's the real deal of your questions. You're not going to have benztropine as an answer choice. You're probably going to have um, diphenhydramine, an H1 blocker, as an answer choice for acute dystonia, beta blockers for akathisia, and possibly amantadine for Parkinsonism. And then deutetrabenazine and all that there. So if they had H1 blocker as an answer choice, that would be the correct answer, but they didn't have that. The other answer choices don't really fit acute dystonia. Beta blockers, as we just saw, would be for the akathisia. Remember, akathisia is restlessness, right? Which is very sympathetic. It's very much a fight or flight kind of a thing, having restlessness. So giving beta blockers would activate the parasympathetic version. It would stop the sympathetic version, and you would actually be able to rest, right? That's the concept you want to think of there to remember beta blockers as an answer choice. Restlessness is basically having too much sympathetic output. Akathisia is restlessness. Don't forget the vocabulary there. And then if you're restless, all you need as a treatment is to somehow be able to rest, which would be a beta blocker or something else that can activate parasympathetic stuff, right? Activating acetylcholine stuff. But that's the benztropine, which we're not seeing as an answer choice, right? So here, anticholinergic agents, right? This patient has acute dystonia due to decreased dopamine in the nigrostriatal pathway, where dopamine and acetylcholine counteract each other. Very important, tiny physiological thing that you do need to know, that dopamine and acetylcholine are on a checks and balances system with each other. So if someone has too much dopamine, they're not going to have much acetylcholine activity, and vice versa. So when you don't have any dopamine, such as people who are taking antipsychotic medications that actually block dopamine receptors, then you're going to have too much acetylcholine activity, which is what leads to the restlessness they start feeling. So to correct the movement disorder, we must decrease the acetylcholine by giving anticholinergic agents. That's it. Then they're actually able to stop being that restless and jittery and whatever. Right? So that's the general idea of side effects of antipsychotics. Now, first thing we're seeing here, SSRIs, the general single brush solution for a whole bunch of issues. Right? SSRIs are like one of the most commonly prescribed medications in the psychiatry department. Fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram. There's a bunch of them. There's more than just this. Unfortunately, they're not all named in the same kind of way. There's no protocol for naming SSRIs for whatever reason. So it can become very confusing when you see answer choices like paroxetine and duloxetine at the same time. Right? Even though paroxetine is your SSRI, duloxetine is an SNRI. So it does get a little, annoyingly difficult. But we've had 3 years of med school to try to memorize this and get better at it, because this is really only very prominent here in psychiatry. In other chapters, most medication classes were named similarly. But here in psychiatry, for some reason, obviously whatever psychopath named these medications did not do a good job. Either they had zero creativity, like doing this, venlafaxine, desvenlafaxine, levomilnacipran, milnacipran, citalopram. But you see, the problem is that you can't tell if citalopram and milnacipran are both the same thing or different things. Like, are they both SSRIs? Or is one an SSRI with the other an SNRI? Just by looking at their name, you can't really tell. So you have to go ahead and do your part in, kind of learning that. It's pretty annoying. I would focus on just making sure you know which ones are SSRIs. Right? Those are the most prominent medications. Those are the more commonly prescribed medications. Do your best to actually know these. Know all of these. And there's more than just these. So you should Google SSRIs and get their names down. Possibly even add it here. Other books mention some more of them, like Crush Step 1. That book mentions 2 other ones that I honestly cannot recall at all. But you want to be at a term with these in such a way that when you do see them in an answer choice, that it should ring a bell, like, oh yeah, I remember that. That's an SSRI. Right? And then if you don't have any recall of a certain medication you see, you can guess that it's probably not an SSRI. Right? And then you'll be okay, or a little better off at least. So SSRIs just inhibit serotonin reuptake, which of course is a huge hint at possibly getting serotonin overdose, which leads to serotonin syndrome, right? Clinically used mainly for depression, but can also be used for generalized anxiety disorder, panic disorder, OCD, bulimia, binge eating disorder, social anxiety disorder, PTSD, premature ejaculation, premenstrual dysphoric disorder. Now, although they say you could use it for premature ejaculation, it's rarely actually used for premature ejaculation. It's maybe because premature ejaculation is less common of a problem. The bigger problem here is that it can actually cause sexual dysfunction. So, anyone having premature ejaculation, the way it's helping those patients is by actually causing or instilling sexual dysfunction in them, not letting them orgasm, right? So then that's kind of the balance of concept there. It's not really a treatment for premature ejaculation. It actually has a bad side effect of sexual dysfunction, which turns out can actually be helpful for someone who might have premature ejaculation. But the side effects here, although not many, they're pretty critical. One, definitely very critical, serotonin syndrome. Then the other very critical one, possible SIADH, syndrome of inappropriate ADH, where you have too much ADH, and this time it's not due to some kind of lung cancer. So then after doing chest x-ray and not seeing any kind of nodules or anything like that, you check if it's nephrogenic problem, and it's not, there's nothing wrong with the kidney either. So then you realize that it must be a medication side effect, and that is a very difficult answer choice sometimes. Medication side effect, picking that as an answer choice. But when you see medication side effect as an answer choice, you should really reevaluate each of those medications. And somewhere in your mind, it should ring a bell that SSRIs are going to affect ADH output, right? You're going to have too much ADH, which of course is anti-diuretic hormone, so you have too much water retention, and that's what you kind of look for, right? And then patients almost 100% of the time will come complaining about sexual dysfunction. And that's very unfortunate, because obviously sexual activity is related to happiness, and if these are people that are depressed yet they have a spouse, their depression is only going to get further worsened when they cannot please their spouse, right? And if their spouse says something, remember, depressed people are usually very sensitive to more negative stuff, and it's just a downhill effect right there. So it's very unfortunate that SSRIs can cause sexual dysfunction. Otherwise, they would definitely be the golden medication, because they already are quite the golden medication with all the things they can help with, right? Now, they don't talk about it much, and they don't really mention it anywhere else in the book, but one of these things, the thing that can help, is premenstrual dysphoric disorder. This is something that you can get in a question that you may not realize is premenstrual dysphoric disorder, because you have no idea what that is. Very rarely discussed topic. I wouldn't say PMDD is a high yield topic, but what makes it a high yield topic is the fact that serotonin reuptake inhibitors are a high yield topic. So since it's related to a major class of drugs, PMDD is now a major thing, right? So PMDD causes severe irritability, depression, or anxiety in the week or two weeks before the period actually starts. Symptoms usually go away 2 to 3 days after the period starts. So you can actually think of PMDD as some level of PMS. It is a premenstrual symptom. Right? So premenstrual dysphoric disorder is literally in the name, right? It's premenstrual dysphoria, right? So they're having, or you can even think of it as premenstrual depression, right? And you'll see the cyclical nature of this, where every time their period is about to come, or right before their period, they have severe irritability and depression. So again, it's just a very unique thing you need to watch out for. They might have other things in the question that they might try to confuse you into, but it's just PMDD, right? They think they're real sneaky by just listing it here but never actually talking about it. So this is what you're supposed to do when you're studying. You look it up, you add more things about it. Turns out it is a very simple thing that didn't really need to be talked about much, but still doesn't hurt to actually look it up, right? Now, next thing you have are SNRIs, right? SNRIs. So I wrote here, SNRIs are the DMV medications. Okay, serotonin norepinephrine reuptake inhibitors are your DMV medications. The reason this works for me is because there's no D medication here. In fact, up until when I was studying, I don't know if something new has come out, there were no D SSRIs, no medication in the SSRI list. Let's check if there is one now. but there were no SSRIs that started with a D. So we got, actually in the real world, there's citalopram, escitalopram, fluoxetine, paroxetine, sertraline, which are apparently the most commonly prescribed, and that's all the ones that we have listed here. Yeah, still doesn't look like there is one with the. Let's see what WebMD says. Actually, let me put in list of medications list. There you go. Yeah, still doesn't look like this one was D. Yeah, so, you know, DMV medications: duloxetine, milnacipran, and venlafaxine. Which, of course, then there's the other ones which have the same name in it: desvenlafaxine and levomilnacipran. Right, so it's just 3 medications basically. You just need to memorize these 3 medications. This the DMV of SNRIs, right? That's it. So you never confuse them during your test day, because it is very easy to start confusing yourself into thinking duloxetine and paroxetine go together. And they're not the same thing though. Even though they end in the same teen in the end, they're not the same thing. Alright. SNRIs inhibit the reuptake of both serotonin and norepinephrine. So remember, norepinephrine is an adrenergic thing, works mainly on your alpha 1 and beta receptor. So again, very important little thing. Well, little if you're in step 2, but major thing in step 1, because it's a huge farm topic, was what receptor these guys worked on. Right now, if we look at epinephrine, norepinephrine, and phenylephrine, it was a huge thing. Farm questions asking in step 1 about what receptor things go on. So remember that norepinephrine mainly is an alpha thing. Okay, it has very high activity on alpha 1, and then at higher doses it can fill alpha 2 and beta 1. But what's really weird here, very interesting medication, very interesting hormone in general, is that remember that alpha 2 actually stops alpha 1 and beta 1 activity. It stops it, minus sign. Right? So if you have a low dose norepinephrine, you'll mainly cause alpha 1 related vasoconstriction, which will then help against hypotension, right? Now, if you give a higher dose, you actually turn on alpha 2 receptors, which are anti-sympathetic stuff, so then that's weird. And if you get a very high dose, then you also have some effect on beta 1. But this is a very interesting thing here, because if you turn on alpha 2, you essentially turn off alpha 1 and beta 1. But norepinephrine is actively turning on alpha 1 also, so it doesn't work. Basically, the alpha 2 activity does nothing. Alright, the alpha 2 activity does nothing here, because you've turned on the alpha 1 receptor. Like, you're actively in there keeping this turned on. So now when you turn on alpha 2, this is supposed to turn alpha 1 off, but it can't, because there's somebody who's actively keeping alpha 1 on, which is the norepinephrine itself. Alright, so you get the vasoconstriction as well as decreased sympathetic output, right, which again is something that has been pretty helpful, mainly with septic shock. Right, very helpful with septic shock. Coming back to the very beginning, if we look at it, and again, you always want to revise this shit as much as you can. Alpha 2, as you can see, decreased sympathetic outflow, so it stops everything, stops all of these guys, all your sympathetic output, it stops all of them, right? And on top of that, it reduces insulin release, reduces lipolysis, so you can basically, without the lipolysis, you won't have the dyslipidemia issue. Decreases aqueous humor production, which we care about. We looked at that when we were in neurology, looking at the eye. And increases platelet aggregation, which basically I like to think of as decreases bleeding, right? So because remember, alpha 2 is inhibitory, it's GI, it inhibits everything, right? So that's the general idea there. But with alpha 1, you have increase of most of these things, right? Increased contraction of most of these things. These are all different things being contracted harder, right? So beta 1 over here is for the heart, as we've already seen. So as you can see with norepinephrine, if you're going to increase vascular smooth muscle contraction, you're going to increase your blood pressure. That's good. And with beta 1, at super high doses, it would work on beta 1 as well. It would also increase the heart's activity and increase renin release, which would also help bring up your blood pressure. So someone who's getting through really bad shock and has become really, really hypovolemic, giving norepinephrine is wonderful, because you revitalize everything, right? You revitalize their blood pressure, and you activate their heart to work harder, and you cause renin release, which is key for dealing with hypotension. So it works out beautifully. With epinephrine, it's different. Epinephrine does not do all of those things, and phenylephrine is also different. So you get tested on the differences between these things. Epinephrine mainly works the other way around. So you see it's backwards. Beta 2, beta 1, then alpha 1. Backwards. Opposite of norepinephrine. Right, so you need to memorize who works how and which one is backwards because you get tested on that quite often. Right? And phenylephrine, all the way down here, only works on alpha receptors. So it's very easy. It just works on alpha receptors. There's nothing crazy about it. Okay. So norepinephrine versus epinephrine. That was the general little side topic right there. Now SNRIs, duloxetine, milnacipran, venlafaxine, they're used pretty much for the same things you would use SSRIs for. The only additional thing here is the diabetic neuropathy. It can help with diabetic neuropathy. And then venlafaxine was an answer choice for many things. Venlafaxine is a little special. It's indicated for social anxiety disorder and panic disorder, PTSD, OCD. It's a very good answer choice you can always pick. Okay. Another thing is you can see SNRIs don't have that weird, terrible side effect of sexual dysfunction. In fact, most of these side effects are completely benign. These are very non-specific side effects. So theoretically speaking, I can never give you a question on SNRIs where I'm primarily testing you on side effects. What am I going to tell you? The patient became nauseous? That would be nothing, because what would you have to gain from that? So that's not really going to be a topic. Duloxetine and milnacipran are also indicated for fibromyalgia, which is another key little thing. We looked at fibromyalgia back in MSK in the same area when we looked at other musculoskeletal inflammatory things. Fibromyalgia is not inflammatory. One of the special things about fibromyalgia, it was discussed with polymyalgia rheumatica, which is inflammatory. Remember, the polymyalgia rheumatica was also related to the inflammation of the blood vessels, which can lead to temporomandibular joint, temporal artery or giant cell arteritis. Right, giant cell arteritis was related to polymyalgia rheumatica, and they're both treated with prednisone because it's inflammatory. And we know that our temporal arteritis had a risk of blindness in it, right? So you typically get a patient coming in saying they have pain all over their body, mainly the shoulders, the hip girdles, stuff like that. Very random. Medication isn't really helping much. They also may have headaches. Maybe they have some jaw claudications. Right away, you're like, oh, this is definitely polymyalgia rheumatica (PMR) with potential giant cell arteritis or temporal arteritis. What do? You give them high dose prednisone before you even test them for anything, because you don't want to wait for biopsy results. There's a risk that they might go blind. Right after that, in MSK, the next topic is fibromyalgia, which is not inflammatory. So your question will not show you that they have elevated ESR or elevated CRP, any of that. One of the things in fibromyalgia, besides the myalgia part, is the fibro, which is not for fibrosis. Fibro for actually having some level of fibro fog, as they tend to call it. So fibro fog is basically inability to really focus or pay attention. Their mind is very fogged out. On top of having a very fogged out mind, they also have some weird bodily pains that don't really tend to resolve very well with medication. So with the fibro fog aspect, you could fix with duloxetine or milnacipran, right? Because it is a stimulant in the sense that it increases norepinephrine activity, right? So you can see that it has stimulant effects, which although it's listed as an adverse effect because it may not be the main thing you want the medication to do, it is great that it has stimulant activity because it's going to be good for all of these people to have some stimulation in their life. Right? Then you have your notorious TCAs, which we discussed in good depth about the convulsions, cold cardiotoxicity earlier, and we looked at how to treat most of these. We also understood that there's some anticholinergic issues happening here. Right? So these are all, again, named very weirdly. Very easy to not really be able to tell them apart if you're not solid about knowing their names. But generally speaking, they do all have amine in the name. Okay, so tricyclic antidepressants, we have amitriptyline, nortriptyline. Then you have a bunch of amines: imipramine, desipramine, and clomipramine. And then doxepine and amoxapine, which are the weirdest. These names don't fit anything here. So you have 3 different end suffixes for these names, which again, I don't know why they did this, right? That's really stupid. TCAs similarly inhibit both serotonin and norepinephrine reuptake. They act very much like SNRIs, except they have far more bad side effects. Clinically used for MDD, but it's not the first line of medication for MDD. Peripheral neuropathy, chronic pain, migraine prophylaxis. Again, not the best thing for migraine prophylaxis either. Clomipramine can be used for OCD, and imipramine can be used for nocturnal enuresis. Again, we've talked about imipramine being a potential medication for nocturnal enuresis, but we know that the first line of medication was star charts or something else, motivational therapy, right? Where you tell the child, every night you go without peeing, I'll give you $1. Some basic example like that. And then the second line was to use your ADH analogs, not imipramine. You don't want to give a child imipramine. Adverse effects are plenty. You have your anticholinergic adverse effects, right? You have tachycardia and stuff like that. The urinary retention and dry mouth, all of which are anticholinergic stuff, like atropine overdose. You also get your convulsions. You could go into a coma, and there's really bad cardiotoxicity. So you can't even use it on a patient who may have QT interval prolongation or other cardiotoxic events taking place to begin with, right? If you give this to a patient and they end up having cardiotoxicity, you have to immediately give them what was the treatment? NaCO3, sodium bicarbonate, right, to prevent the arrhythmia, because this actually fixes the sodium channel inhibition that's occurring. They can also get respiratory depression. So there's many ways they can die, and it's just not a good medication to give someone. You really don't want to give to someone elderly either, because you'll probably kill them. So all in all, it's like, I'm not sure why this class of medications exists, because we would never really want to use this for someone, right? There's many other better answer choices to pick. So try avoiding picking one of these things, which is great, because then you don't need to worry too much about memorizing these. You should have a good enough understanding of what they are, just so you remember them enough so that when you see them in an answer choice, you can know what they are. But the main ones you do need to know are your SSRIs, and then the SNRIs, and then after that, possibly tricyclic antidepressants if you get time, which you should get time. Last thing are your monoamine oxidase inhibitors. The only reason you need to know these is because it's not that you prescribed it or something. Your patient may have already been on one of these medications, and then eventually they show up with some weird side effects. You'll have to understand that they took a MAO inhibitor and ate tyramine, like an idiot. So tranylcypromine, phenelzine, isocarboxazine, and selegiline. Completely irrelevant names. They're all named really different from each other. Right? These are selective MAO-B inhibitors. Generally, they can cause non-selective MAO inhibition, but they will act. Selegiline is the only one that's selective. Generally, these guys cause non-selective MAO inhibition, which then leads to increased amounts of neurotransmitters. Remember, the MAO was a monoamine oxidase. Its job was to break down serotonin and break down norepinephrine, so you no longer break them down. So you have a lot of norepinephrine floating around and a lot more serotonin floating around, and you're still making new norepinephrine and serotonin as well. What does it do? It helps with atypical depression. It helps with anxiety. Selegiline is also a medication for Parkinson's disease. Adverse effects include CNS stimulation, hypertensive crisis, most notably with ingestion of tyramine, which is going to be the thing you're going to see. Contraindicated with any of these other medications. So again, you need to know these medications, because you can get these contraindication questions where a patient may be taking St. John's wort. Now, if they're taking St. John's wort and they just started taking some new medication for their atypical depression or some new medication for their Parkinson, then you have to understand that they're mixing a MAO inhibitor with one of these things, and that's bad. Because if you do mix them, then you can precipitate serotonin syndrome. Since monoamine oxidase inhibitors do increase the amount of serotonin you have available, and if you mix it with something else that also increases how much serotonin you have available, you get serotonin syndrome. Wait 2 weeks after stopping MAO inhibitors before starting any new medications or stopping dietary restrictions, right? So don't eat tyramine related stuff until at least 2 to 3 weeks have passed, just to be safe. So that's definitely a pretty common problem. It happens quite often. at least in step, and you have to be very careful with that. Now, what is atypical depression? So atypical depression is really mainly described by something called mood reactivity, which is not a common thing in normal depression. And we see that in this question. 44-year-old man comes to the office due to low mood, impaired concentration, increased sleep and appetite, feelings of heaviness in his arms and legs, and loss of energy. He is having difficulty at work as he is overly sensitive to criticism. Although his boss has told him not to worry, the patient is concerned that his job is in jeopardy due to his poor performance. His symptoms started 8 months ago without any clear precipitating event. The patient received adequate trials of 3 different antidepressants without improvement and has been off of medication for the past several weeks. So more than 2 weeks, we're assuming. His physician is now considering ECT, great idea, but he declines ECT, terrible idea, and asks to try another medication. Now I get it, electroconvulsive therapy could carry some fear, you might be scared about it, and it can carry some stigma, but it's actually really freaking good and very helpful, and anyone that might need it, it's a good idea for doctors to recommend that the patient look more into it and consider it, not just give me an answer right away, and he asked to try another medication, at which point, you might even want to just refer them somewhere else because they're not someone easy to deal with here. But the physician considers phenozine, which honestly speaking is not that good of an idea, but it's happening in this question. The presence of what additional symptom would make this medication appropriate? So besides the fact that nothing has worked and he doesn't want ECT, the thing that would make this medication appropriate is if he has something called mood reactivity. Unfortunately, in this question, this is not one where he's doing mood reactivity, but mood reactivity was the answer here, not auditory hallucinations, which would make this schizophrenia. So then, of course, phenozine would not be the correct answer choice. Not decreased libido, because that would just be a side effect of SSRI, which would not indicate why you would give phenozine. Delusions, that's psychosis also, so it still doesn't make sense why you would give phenozine. Memory impairment is just a side effect that is possible somewhere, still doesn't mean why you would give phenozine. And rapid speech is something you see in mania, possibly hypomania, so then that would be bipolar, which still doesn't indicate phenozine. So you would pick mood reactivity even if you didn't know what mood reactivity is about. MAO inhibitors are not first or even second line treatment for depression, but they're still useful in atypical or major depression that is resistant to treatment. Atypical depression, now it is possible he might just have major depression resistant to treatment, which would actually make this a correct answer choice to give him phenozine, but he might have atypical depression. Atypical depression is characterized by mood reactivity, lead-in paralysis, which is a patient's arms and legs feeling extremely heavy, and rejection sensitivity, where they're overly sensitive to slight criticism, as well as reversed vegetative signs of increased sleep and increased appetite, which is not what you see in typical depression, where people don't want to eat at all and they barely can sleep. The main distinguishing characteristic of atypical depression is the mood reactivity, which is feeling better in response to positive events and feeling bad again when something negative happens. Right? That's mood reactivity. That is not something you see in typical depressed people. Typical depression does not have that. All right. Last group of things here, atypical antidepressants. So here we see once again our boy bupropion. So we saw bupropion. It was with the norepinephrine reuptake inhibitors. It inhibits norepinephrine and dopamine reuptake. Also used for smoking cessation. Right? Toxicity, stimulant effects like tachycardia, insomnia, headaches, seizures, in bulimic patients. You don't want to give bupropion to a bulimic patient. It has a favorable sexual side effect profile. So side effects get tested. So remember, bupropion turns you on, stimulant effect, and favorable libido, but do not give to bulimics. Right? Very important. Can also be used to treat this very specific thing, seasonal MDD, seasonal major depression disorder, which we talked about when we looked at MDD, that this is a case scenario where a patient has MDD every same season, so once a year. Right? Formerly seasonal affective disorder. Seasonal MDD is in which people who have normal mental health exhibit depression at the same time every year, like every winter maybe. Right? It's actually pretty common. We saw mirtazapine, which is your alpha-2 antagonist, right? It increases the release of norepinephrine and serotonin by blocking alpha-2. Right? So it also has a potent serotonin receptor antagonism and H1 antagonism. So ultimately, all it does is increase norepinephrine activity, because although it increases release of serotonin, it's also got serotonin antagonism. So all that's really going to be doing anything is norepinephrine. Toxicity can lead to sedation, which may be desirable in depressed patients with insomnia. Right? So you're actually using the side effect as a main treatment. It can also increase appetite and cause weight gain, which again may be desirable in underweight patients, and it can cause some dry mouth because of the anticholinergic activity aspect. Right? So very interesting medication, very commonly used, very helpful, because it can fix things that patients may not be able to fix themselves. Like you need to eat more, you need to sleep more, they can't do it, then you give them mirtazapine. All right, atypical antidepressant. Trazodone primarily blocks serotonin and alpha 1 receptors as well as H1 receptors. Also weakly inhibits serotonin reuptake, used primarily for insomnia, as high doses are needed for antidepressant effects, so it doesn't have many antidepressant effects. Toxicity can lead to sedation and priapism, which is often tested. Right? So think trazodone. Trazodone is to remind you that it can cause the boning effect of priapism, having a boner or having an erection pretty much all night or at some point early in the morning, and it's just for no reason whatsoever. That is something that you might see here. Right? Male specific side effects. So you can see that the male specific side effects are a pretty typical thing that's being tested here, because there is a problem in the psych department. When patients come in to get new medication, the men are worried about having libido defects, and the female patients are worried about weight gain defects. They're also worried about some level of libido, but not really. They're not really that worried about libido defects. Usually, they're not even very much interested or looking to have any intercourse at that point when they're looking for this psychotherapy. But weight gain tends to be the bigger issue for them. So you care about all of those things. Now, we just saw that bupropion was also used for smoking cessation, which is definitely a very helpful thing. Varenicline is the better thing there, right? So varenicline is in the name, nicotine decline, right? So that's what's written here. Varenicline helps with nicotine cravings decline. Nicotinic acetylcholine receptor partial agonist, used for smoking cessation. It's actually very helpful, but it can actually cause a depressed mood. Now, I'm not sure how they may have studied that, because if you're giving somebody varenicline and then you're telling me now that they have a depressed mood, I'm not sure if it's really the varenicline that's causing a depressed mood, or is it because they haven't been able to smoke, right? Is it a withdrawal symptom of some level from not having a cigarette? So there's more study to obviously be done there, but varenicline is a medication you pick when someone comes in and they need help quitting smoking. It's also a better answer choice than bupropion, because bupropion lowers the seizure threshold. So if someone was like this close to having a seizure all their life, now you close the gap and they can start getting seizures. Right? So you don't want seizures. Right? Not only in bulimic patients, it lowers the seizure threshold anywhere. It's more possible for bulimic patients because bulimia increases the chances of seizures, but you can get seizures in anyone. So if they're an epileptic, you probably don't want to give them bupropion. Right? Vilazodone, this one is mainly used for MDD. Another little side medication, inhibits serotonin reuptake. It's like an SSRI. It has anticholinergic effects. May cause serotonin syndrome if taken with another SSRI, but honestly, I don't know the purpose of this and why this isn't just labeled as an SSRI, because it is functionally, essentially, an SSRI. Right? Vortioxetine, this is also theoretically an SSRI. Right? It also inhibits serotonin reuptake, acts as a 5-HT3 antagonist. Honestly, I don't know the difference between the different serotonin receptors and what they do. You don't really need to know it. But it is used once again for MDD and has the same profile of side effects. So all in all, it's safe for you to think of vilazodone and vortioxetine as more SSRIs. Okay, varenicline is the only V medication that has nicotine decline. Is for smoking cessation. You come back and revise this again tonight. Revise it whenever you can so it sticks to you. All of these guys, this one page of medications with your main guy being the SSRIs, right? You basically want to think of your V guys here too. Vortioxetine, vilazodone, right? They're also SSRIs in functionality, not actual class, but in functionality. Now, there is something you can get tested on. This is also tested on CK quite often. Antidepressant discontinuation syndrome. As I'm sure you can imagine, acute symptoms following abrupt antidepressant dose reduction or discontinuation. This is just anyone who stopped taking their antidepressants because now they're better and they've been pretty well over the last few months or something. All of a sudden have some weird symptoms. This may include dysphoria, fatigue, GI distress, flu-like symptoms, balance difficulties, sensory electric shock disturbance, and irritability more common with abrupt SSRI discontinuation than TCA discontinuation. But who's taking a TCA to begin with? Mainly what you're seeing, what you're looking for is someone who randomly just all of a sudden stopped taking their SSRIs. So you can get an ethics question where you have to have a conversation with your patient. You should tell them to slowly discontinue their SSRIs, not just cut it off, right? Abrupt MAO inhibitor reduction may even cause psychosis. So there's a lot to watch out for. Treatment is generally just to restart or increase the dose of antidepressant and then correctly slowly taper it off rather than randomly finishing it off all of a sudden. Opioid withdrawal and detoxification is the last thing here. Obviously a very high yield topic. You get tested on this a lot. Very huge issue in America overall. Kind of becoming a smaller issue now, probably because of the pandemic, making it difficult for people to actually get their hands on opioids. But it's an issue that still hasn't really been solved and can always resurface. So you've got a couple things here: methadone, buprenorphine, naloxone, and naltrexone. The main thing here is naloxone. Key thing: naloxone is a short-acting opioid antagonist given IM, IV, or as a nasal spray. So you have to look if the question mentions that a nasal spray medication was given, but the question is being an asshole and not telling you naloxone was given. You have to understand that naloxone was given to treat acute opioid overdose, particularly to reverse respiratory CNS depression and save a life. So this is the number one medication, right? You can see that it's in the name, right? This is number one medication for anyone with opioid overdose, save a life. Perfect. After this, the next medication you need to know very well is buprenorphine. Buprenorphine, as you can see, is given sublingually, right? It's a partial agonist used to prevent relapse. So this is something that the patient is going to come in for regular visits and you're going to give them buprenorphine. They're going to take it and they're trying to let go of this opioid addiction they have, right? Because it's not really under their control. Losing an opioid addiction is far harder than losing a cigarette addiction. Opioid addiction literally puts you in pain when you don't have the opioid because all your receptors are not working and your body is getting these weird signals of being in a lot of pain. And depending on how long the addiction has already been happening for, the pain is that much worse, right? So this is being a partial agonist. It's actually something that is kind of sort of doing an opioid job, but not really. So it relieves them some pain, but at the same time, it doesn't increase their addictiveness, right? So that's buprenorphine. This is the only real partial agonist that you need to know. After that comes methadone, right? So when you say methadone, you shouldn't think of the one here. This is just, it's done, right? So it's done. That you look at the whole word done. This is a long-acting oral opiate used for heroin detoxification or long-term maintenance therapy. So basically what's done here is that the patient is no longer really that addicted to their opioids, and their acute overdose part is also done. They're not acutely overdosed anymore. This is something you give for long-term therapy. A lot of times patients take both buprenorphine and methadone for their long-term maintenance and preventing relapse, right? Because you want to stop them from one day just going back to opioid addiction. So then what is naltrexone for? Naltrexone is also a long-acting oral opioid antagonist. Now, there's a difference between methadone and naltrexone. Methadone is an opiate. Naltrexone is an opioid antagonist, but they're both long-acting. So how do they differ? Well, naltrexone is used after detoxification to prevent relapse, while methadone is used during detoxification. Remember that heroin, by the way, is the same thing as an opioid. Heroin is an opioid, right? One of my cousins actually, who had just recently come from Pakistan, actually failed their step 2 CS way back because, amongst other things they probably might have done wrong, one of the major ones was they had no idea what it meant when a patient said they do coke, which actually meant they do cocaine. So heroin and cocaine and stuff. I mean, in America, most of us know what cocaine is, but heroin is something that you have to understand too. Heroin is actually just opioid. It's the same thing, right? In fact, heroin is much easier to get than getting actual opioids. You know, you can't get your hands on oxycodone that easily. Um, it would take a lot of hard work. But getting your hands on heroin might be significantly easier. It's also significantly cheaper. There's a bunch of factors that involve people being easily able to get heroin. And heroin is also the bigger reason a lot of opioid overdose incidents actually occur. Because when you get one pill of oxycodone, you know exactly how many milligrams it is, what the dosage is, and stuff like that. You go buy some heroin, you don't really know what else is mixed in there. You don't know how much dosage you're taking, and then it ends up having a different effect because obviously different from oxycodone, right? So again, if you get a question, you're probably gonna have all four answer choices there. Naloxone is a very simple thing. It's strictly for saving a life. It's the number one medication for acute overdose. Buprenorphine is a partial agonist for preventing relapse. Naltrexone is something you use after detoxification for preventing relapse, right? It's for the long treks back to sobriety. Methadone is what you use to actually help get over it, right? Once you get over it, it's done, right? So how do you help get over it? It is actually an opiate. How do you help somebody with their addiction? You give them what they're addicted to. That's actually a fact. You can't help somebody with an addiction by taking away what they're addicted to. You have to give them some level of what they're addicted to and then slowly take it away while naturally, making their body get used to the lower amounts of that thing they're addicted to, right? And that's generally all that's happening here. UWorld actually had a question on varenicline. So they have this picture here kind of showing you how varenicline is blocking the receptor for nicotine. You see that? It's not actually fully fitting in there either, but it blocks it, so nicotine has no effect there. All right, so however, by somewhat fitting in there, it causes partial stimulation of the receptor, so it reduces nicotine withdrawal. So you see how to save someone from something, you have to give them that thing in some level, right? So this thing is still activating the same receptor that nicotine would, but it's not fully activating it. Right, so it prevents nicotine from binding and inducing a reward response, but it still reduces nicotine withdrawal also, right? So that's kind of how mechanism of action of varenicline works. They talk a lot more about it, and that's basically it, right? Very, very straightforward. This last thing here is a drug toxicity question about obviously lithium causing nephrogenic diabetes insipidus. Again, if you don't understand how to really break down diabetes insipidus, how to identify nephrogenic versus central diabetes insipidus, how osmolality works, and those are all things that have already been discussed in great depth in the endocrine lectures. And if anyone has a question, you can always reach out to me. We can break it down a little more. We can talk about it. But generally speaking, this should never be something you're confused about. This is actually a very good and easy question that you can never get wrong on your step. And any of these questions regarding these topics should always go right. The more things they put into a table, the more chances you're going to get it right, because you'll know what's not right and you'll be able to rule out answer choices. You'll have more reasons to rule out an answer choice. That's how you really want to see about it. This is what that really means. So you have 4 reasons in these 5 answer choices to rule out each answer choice. And ultimately, C would be the correct answer here. So, take a look at that. So E would be the correct answer here, the one that's boxed like that. And then take a look at that, make sure it makes sense, make sure why it's like that. And of course, you also need to know the normal numbers for all of these things. It is given, but it takes too long to actually figure that out. So you should write the normal numbers down for yourself on your cheat sheet just so it's there. And that's it. In our next video on Wednesday, we'll continue on into renal disease.